Is it visible now?
Sorry, Dr. Sanjay,
Yes,
I'm
it
back.
works. Go ahead.
Yeah.
I can hear you too. Right.
Okay. Is it visible? Yes.
Yes. Yes.
Okay. Okay. Thank you. Thank you. Thank you, Dr. Park, Dr. Adit. Namaste to everyone. Good afternoon to the participants who are living in this part of the world, and good morning who are from New York and Brazil, and good evening to the participants who are living in Seoul. First of all, I would like to thank Director Dr. Jae-bong Park for inviting me as a speaker and giving me the opportunity to share some knowledge to you people. And I also like to thank our panelists, the great orthodontist, Dr. Adit Venugopal.
Thank you so much.
Welcome. Basically, I am from Nepal. Some may not know this country, so I'm going to give some information about this country. It is a landlocked country between the two giant countries, India and China. The bordering from the north side by the China, and bordering from the south side, east side, and west side by the India. And around 147,000 kilometers of land it is occupied in the Nepal, and around 3 crore of the people are living in Nepal. Okay, though it's a small country, it is also known for this Himalayas as the 8th out of 10th highest peak are located in Nepal, including the tallest Himalaya, that is Mount Everest. And it is also known for the country where the Buddha was born, and also known for the country of temples, where many temples are located, including this World Heritage Sites, and it's also known for its natural beauty. So I would like to welcome you all to witness the gift of the nature. This is where I have been working since 8 years in Tribhuvan University Teaching Hospital, Grand International Hospital, and my private clinic, Dental Villa. So the optimal management of missing maxillary lateral incisors continues to cause the controversy within the specialty, and the opinions remains divided whether to open the space of the missing lateral incisors followed by the prosthesis, or whether to close the space and followed by the lateralization of the canine. So in today's this presentation, I will be covering under the following headings: introduction, the decision making between replacement versus canine lateralization, modification in the treatment mechanics, some case series, and then conclusion. Let's start with the introduction. The variation of the maxillary lateral incisors are more than any other tooth except the third molars. Whether it's agenesis or microdontia, the maxillary lateral incisors are the most common tooth which has got variations. And the maxillary lateral incisors agenesis, it is the most prevalent developmental dental anomalies. Regarding the prevalence, the studies show that it is more prevalent in Asian peoples and in females. Whereas among Nepalese orthodontic patients, our studies show that the prevalence of maxillary missing lateral incisors is 5.82%. So there are various etiology, or there may be various causes like trauma, infection, medications, mutations of genes like MSX genes, PAX9 genes, and some syndromes like ectodermal dysplasia, Down syndromes, and cleft lip and palate are involved for the agenesis of the maxillary lateral incisors. So the patients in which the teeth are missing, they might be suffered from this deficiency in the chewing or reduced chewing efficiency, inarticulate pronunciations, and the aesthetic appearance that ultimately affects the communication, behavior of the patient, self-esteem, and the professional performance. So the management of missing maxillary lateral incisors, either we have to close the space and use the canine as a substitution for the missing lateral incisors, or either we have to create the space orthodontically followed by the prosthetic replacement. So for decision making, there are various. We have to we have to be careful in the diagnosis and the treatment plan, as I have to address the patient's need as well as by my multidisciplinary approach, as the defect is located in the aesthetic region of the jaw. So it will require the multidisciplinary approach. So there are various factors that should be considered, like the size of the canine, whether it can be converted into the lateral incisors or not, the shape of the canine, whether it is favorable to convert it into lateral incisor, or the color of the canine. If it is matching with the central incisors, then it will be the good candidate for the canine lateralization. And also the age of the patient. If the patient is too young, then we have to think of this space closure rather than going for this prosthetic replacement, as it will require the longer duration of the treatment. Also, we have to look for the profile of the patients, whether the profile of the patient is straight, convex, and also we have to look for the smile line and the two sides Aslan discrepancy, whether this patient is having crowding or spacing, and the ridge thickness, existing occlusion, whether the patient is having the class 1 molar relation, class 2 molar relations, and the patient's expectation from the treatment, what the patients want from us. And the next factor is the cooperation for the patients. These are the factors that should be considered while decision making between this space closure or space opening followed by the prosthesis. So the management of this missing maxillary lateral incisors continues to cause controversy within the specialty, and the opinions remains divided, which is evidenced by this point and counterpoint discussions, which was published in 139 volume of American Journal of Orthodontics and Dentofacial Orthopedics in 2011. The Jackson et al., who are in favor of this space closure followed by the canine lateralization, and this Kokich et al., who was in favor of this space opening followed by the prosthetic replacement. These two are very nice articles. You can go through it. Not only this, in light of this, the Angle Society of Europe meeting in 2012 dedicated a whole day to resolve these controversies. And later it was published by Johal et al. In Progress in Orthodontics as a report in 2013. So the first option is the space opening followed by the prosthesis. It is indicated where the enough room is available in the maxillary arch. And the cases which is having the maxillary lateral incisors, that need to be protruded to correct the anterior cuspide or to gain the lip support. In that cases, we can expand or we can open the space for the prosthesis. So there is one philosophy that the cases who do not meet the specific qualifications for the canine substitutions, an alternative form of treatment, that is prosthetic replacement, can be considered. So how much amount of space we needed for the replacement of the missing lateral incisors? That will be determined by the two factors. The first one is the aesthetics of the mesodistal width, and second one is the occlusion. The width should follow the golden proportions. That is, the lateral incisor is 2/3 of the central incisors when we view from the frontal side. That is, lateral incisor, it should be 62% of the width of the central incisors. So basically, for restorative alternative or prosthetic replacement of lateral incisors, they are broadly classified into the single tooth implant and the tooth supported prosthesis. And again, the tooth supported prosthesis, it is divided into three parts. That is the three types. That is the resin bonded fixed partial denture, and the cantilever fixed partial denture, or conventional full coverage FPD. The choice between these four options depends on the less invasive nature, as well as that will give the best aesthetic outcomes as well as the functional outcome. We have to take care of those things. So the single tooth implant option is the most biologically conservative and most commonly used methods for replacing the lateral incisors. So for about 3.75 millimeter of implant fixtures, we need to have at least 6 millimeter of interdental space that will provide the optimal gingival health and sufficient bone support. Nowadays, we can use the less thickness of the fixtures also, 2.9 mm, 3 mm of implant. That will eliminate this more interdental space requirement. And in some cases, if the bony support is not enough, then we have to go for the alveolar bone augmentation procedures. So what are the appropriate time for placing the implant? It should be placed after the end of the facial growth, as if the face grows and the mandibular ramic grows, the teeth have to erupt to maintain the proper contact, and the implant does not erupt. So if we place the implants before the end of the facial growth, then it will lead to significant periodontal occlusal problem, that is infraocclusion, and the severe aesthetics problem. So the ideal time for the implant placement in case of male is 20 to 21 years, and in case of female it is 16 to 17 years. So what are the benefits of creating the space followed by the prosthesis, or advantages? The advantages of this option, both functionally and occlusally, that favors an ideal intercuspitions through the canine and the premolars, and there won't be any need for the maximum equilibration, or minimal equilibration will be required, and minimum reshaping of the sound teeth will be required in this option. What are the cons? What are the disadvantages of these options? That is the permanent prosthesis in the aesthetic area, which is very critical. So the tooth shape, gingival contour, and the margins are not always easy to control. So another options for managing this missing lateral incisors is the orthodontic space closure followed by the canine lateralization. It is indicated in which the patient is having the small canine with shade that matches with the central incisors, and the patient is having the straight profile, class 2 dental relation without crowding the lower arch, and the class 1 dental relation with crowding the lower arch. Minimal or no space available in the maxillary arch, and the canine and premolars of similar size. These are the ideal indications for this spaceful closure followed by the canine lateralization. So in case of missing lateral incisors, if the one lateral incisor is missing, then the removal of the contralateral incisor is indicated to obtain the symmetry and having the coincident midline. If the case is having this peg-shaped lateral, or in case of the severe crowding cases. And if the lateral incisor is of acceptable size and shape, then we have to attempt for the only unilateral space closure. No need to remove the contralateral lateral incisors. So canine lateralization procedures for obtaining the optimal aesthetics and the functional results, the canines that need to be transformed into the lateral incisors, aesthetically as well as the functionally, to resemble as the lateral incisors. So we have the three options. Either we have to flatten the tip of the canine by trimming, or we have to build the mesial and distal angles by the composite build-up or veneering, or we have to do both according to the need of the patient. As we know that the gingival level of the canine, it is apical to the lateral incisors, level of the lateral incisors. So we have to extrude the canines so that the gingiva will follow, and then it will be followed by the extensive coarse tip trimming. Also, as this canine are smaller, 1.5 mm wider than the lateral incisors, so we have to do some proximal stripping in canine during the lateralization process. Also, during the canine lateralization, we have to reduce the palatal enamel to reduce the prematurity with the lower incisors. And also, in some cases, the canine labial surface is reduced with care at the end of this treatment, as it will lead to the graying of the surface. We have to be more cautious during this process, and it will also reduce the strain. So the canine labial surface should be reduced at the end of the treatment with proper caution. The main demerit of the canine lateralization, or the more difficult task, is to gain the palatal torque of the relocated canine. It will be solved by this proper bracket selections, and the choice of the bracket, which is primarily based on two factors, that is either the palatal torque of the bracket and the shape of the bracket base. So there is one nice article by Neil Kravis, which was published in Journal of Clinical Orthodontics in 2017, about this bracket selection for the canine substitution cases. Either we can use this canine bracket, we have to flip it 180 degree. Just a minute. Either we have to flip it to convert this canine into the lateral incisors, so that in MBT bracket we can get plus 7 degree of torque. As this canine bracket has got minus 7 degree torque, by flipping it we can achieve plus 7 degree torque, which is similar to the contralateral incisors. And if the cases which is requiring more amount of palatal root torque, then we can choose this mandibular second premolar bracket. That will give the plus 70 degree of torque by flipping it with the 180 degree. Or in some cases, we can use the central incisor bracket, or we can use this lateral incisor bracket. But in these two bracket placements, we have to do the enameloplasty, as the bracket base of the central and the lateral incisor is flat, so that won't be matching with the convex surface of the canine. So we have to do the prior enameloplasty before placing the central incisor bracket or lateral incisor bracket. So during the lateralization procedures, we have to do some maxillary rotation of the maxillary premolars. So have to achieve the better contact point, as well as it will be the aesthetics by hiding the palatal cause. And we have to grind the palatal cause so that it will avoid this interference, as the premolar will be in place of the canine. So we have to grind the palatal cause. In some cases, the labial step out bend in the archways that may improve the palatal root torque and reduces the occlusal trauma on the mandibular incisors. So that will also improve the interproximal contact between the central and the canine. And in some cases, it may require the localized gingivectomy, periodontal surgical recontouring, and vital bleaching, and that will match with the color of the central incisors. So what are the advantages of this space closure followed by the canine lateralization process? The main advantage is the permanence of the finished results and the possibility to complete the treatment in early adolescence. If the patient is young, then for prosthetic option, we have to wait till the patient finishes his or her growth at the age of 20-21 years for male or 17 to 18 years for female. But this space closure option followed by lateralization, we may not need to wait for the longer duration of treatment. And this option is less invasive, and these gingival tissues which we got that will adapt throughout the life with the natural teeth. And what are the disadvantages of this process of space closing followed by the canine lateralization? There are tendency of the space between the anterior teeth to reopen, which can be minimized by avoided by this fixed retainer on the canine and the central incisors. And the canine portrait occlusion, it is not feasible in this case, and the extremely large canine are not the good candidate for the canine lateralizations, as it cannot be adequately reshaped. And the dark shaded canine, which also gives aesthetically unpleasant appearance, so it should not be the good candidate for this canine lateralization process. So there are some studies that claim that that the loss of the periodontal attachment due to the stress placed on the thinner root of the premolars rather than the canine, and some studies regarding this periodontal and the occlusal parameters show that the space closure is equally sound occlusally as well as periodontally. So one study by Robertson et al., they show that the orthodontic space closure produces the results that are accepted by the patients, does not impair the temporomandibular joint functions, and encourage the periodontal health in comparison with the prosthetic option. There is another study by Kadri et al. That showed the space closing was perceived to be more attractive than the space opening by the lay people, and the best aesthetic outcomes when both the maxillary incisors are missing. I'm moving to this another section of my presentation, that is the case series. This is a case of 21 years female having unilateral missing maxillary lateral incisors on the left side. This is the case whether this smaller canine and the gingival level is also which is similar to the gingival level of the contralateral lateral incisors. So this seems to be the good candidate for this space closure followed by the canine lateralizations. These are the pre-X-rays, and we have to gain this palatal root top and the labial crown tuck. So we have flipped this canine bracket and also placed this bracket distally so that it will lead to the mesial rotation of the premolars and hiding the palatal cuffs. So in this way, the space closure was done by each end along with the elastics, class 3 elastics. And finally, we achieved this class 2 molar on this missing side and the class 1 molar on the normal side. So this is how we achieve these results. This is progress and this end of the treatment. This case was recently published in Hindavi Case Reports in Dentistry. You can access this article if you want to. And now there is a one case of a 18 years female having the bilateral missing maxillary incisors. Missing maxillary incisors on both sides with the crowding in the lower arch, which also I already said that if the patient is having this kind of a class 1 with the crowding in the lower arch, and it also seems to be the good candidate for this space closure by extracting this premolar extraction in the lower arch and flipping the canine brackets on the both sides to achieve these results. So Here is the another case of 19 years male having the bilateral missing maxillary lateral incisors and the missing mandibular left incisor. And in this case, the patient does not want to have prosthesis in his mouth. So we have attempted this space closure, though it's not a good candidate as it's this bulky canine. So we have opted for this space closure followed by the lateralization by flipping the bracket. And one incisor, lateral incisors, one lateral incisor is missing on the left side. So at the end of this treatment, we have achieved class 2 molar on this missing side, lateral incisors, and class 1 molar on this side, left side, where this lateral incisors is missing in the upper arch, as well as the lateral incisor is missing in the lower arch, to achieve the normal overjet and overbite. This is how we achieve the result. Here is another case of 22 years female having unilateral missing maxillary lateral incisors with peg lateral on the upper left regions and the odontoma present on the lower left region of the jaw between 3.3 and 3.4. This is the case. Missing lateral incisors and peg lateral. This case also does not want to have prosthesis in her mouth. So we have opted for this canine lateralization process, removal of the odontoma, and finishing the results with the class 2 on this missing side and the class 1 on this normal side. So this case was also published. You can go through it if you want to have detailed information about this case. Another case of 18 years male having the unilateral missing maxillary incisors on the right side, having the missing maxillary lateral incisors on the right side with the class 2 molar relation. So bonding was done with the flipped canine bracket, followed by this residual space closure with the class 3 elastics, where we can get the class 2 molar relation on the missing side, followed by this slight cost trimming, canine tip trimming, and class 1 on the other side. This is how we achieve the results. Here is another case of 19-year female having unilateral missing maxillary lateral incisor on the right side. In this case, we have gone for this prosthetic replacement of the missing lateral incisors. So we took the CBCT and analyzed for this interdental space, bucco-palatal thickness of the bone for implant placements, and then we have placed the implant and followed by the prosthesis. So we are at the end of my presentations. So the choice of the treatment options, it will be depend on the various factors that needs to be careful planning with the multidisciplinary approach, as the defect lies in the aesthetic region of the jaw, and the proper selection of the case, whether to go for the space opening followed by the prosthesis or the space closure followed by the lateralizations. So that this proper selection of the case, it is crucial while decision making. And all the advantages and the disadvantages of both the treatment modalities, it should be well discussed with the patients prior to going for any treatment modalities. And in my opinion, the space closure with the canine lateralization option that seems to be less invasive, then the treatment completed relatively in a short period of time in case of young patient, and the adult patient with the facial changes throughout the life. And the main thing is without having the artificial prosthesis in his or her mouth. I would like to thank you all, especially Director, Dr. Jae-bong